Welcome to another episode of the Zach Highley Show. Today, I have the honor of being with Dr. Austin Chiang. So Dr. Austin Chiang is a triple board certified doctor in gastroenterology, internal medicine, and obesity medicine. He got his BS from Duke, his MPH from Harvard, and his MD from Columbia. His internal medicine training was at New York Presbyterian Hospital. His GI training was from Harvard at Brigham and Women's Hospital, and bariatric endoscopy fellowship was from there as well. He is currently the Chief Medical Officer of the gastrointestinal business for Medtronic. He's also an assistant professor of medicine, and he was the Chief Social Media Officer for the health system as well. He's also the Director of the Endoscopic Bariatric Program, and he's been named the Helio 2018 Gastroenterology Innovator of the Year and been featured on the New York Times, CNBC, BBC News, Men's Health, and many more. Finally, he sits on the inaugural YouTube Health Advisory Board and joined the White House Healthcare Leaders and Social Media Roundtable in 2022. Welcome, Dr. Chiang. Thank you so much for being here.
Thanks for having me.
So the way this starts usually is I go over a couple statistics. Specifically, we're going to start with gastroenterology, and then you just let me know if any of these statistics stand out to you, any of them you want to comment on. Okay, let's get into it. So the median attending physician salary across the U.S. is $339,000. While the GI salary is $397,000. Average hours worked across the U.S. for the average physician is 51 hours a week, while GI is 55 hours a week. 59% of all U.S. attendings are happy compared to 60% of all GI attendings. 47% of attendings have experienced burnout at some time in their career, while 48% of GI attendings have experienced burnout at some time in their career. Step 2 score average is 246 across America, and Step 2 score in GI attendings is 246. Any thoughts on any of these statistics? Any of them pop out to you in any way, shape, or form?
Well, it's kind of nice to hear that we're kind of on par in terms of burnout and happppiness scores.
Yeah.
But in terms of salary, I think it really varies widely. Those are
Yeah.
averages or medians or whatever. But, it really depends on what type of practice setting you practice in, whether it's academic or private practice. Where in the U.S. you're practicing as well, I think makes a big difference.
Yeah.
So the range could be lower than that and also way higher than that, sometimes well into the seven figures.
Wow.
So it really, there's a wide range. I mean, there's a couple outliers out there, I'll say.
Yeah. Actually, random curiosity, what are the different specialties of GI where the salary is higher as opposed to lower? I'm guessing, is academic medicine usually a little lower?
Yes.
And then if you maybe go a little more rural, maybe private practice, you're doing kind of endoscopies and colonoscopies all day. Is it more at the higher end?
Yeah, I think it's hard to say because advanced endoscopy, for instance, especially like within an academic center, could potentially make a little bit more depending on where you are. But if you're out in the community in private practice, sometimes the people who are really generating a lot of revenue are the people who are able to crank out a lot of procedures. Especially currently in our as it stands right now, we're still kind of in a fee-for-service model. And so people who are able to crank out a lot of screening colonoscopies, which is a general GI procedure, end up making, a lot more.
That's interesting. And we're going to get into your extremely interesting background because I definitely want to talk on the social media, the White House, this new job that you have. I think these are all really interesting things. But let's start with the GI. Let's start with gastroenterology and kind of helping medical students or people interested in gastroenterology learn, what is this? Why should I do this? Why shouldn't I do this? So what is gastroenterology?
Well, gastroenterology, which we kind of shorten as GI, which is GI stands for more like gastrointestinal. But it's basically, I would summarize as digestive diseases of the gut. But I think what a lot of people don't realize is that aside from the gut, which we kind of, or I imagine to be sort of esophagus, stomach, intestines, colon, aside from that long tube of an organ, there's also other organs that we have to, treat and deal with. And those include the liver, the biliary system, like the gallbladder, the bile duct, the pancreas, and also kind of less organ-based issues as well, like obesity medicine, the microbiome. These are all hot topics, within gastroenterology.
And why did you pick? How did you get interested in gastroenterology?
Yeah, so I gravitated more towards the field because of the procedural aspect of things, and so which is why I ended up doing advanced endoscopy, which is a subspecialty within GI, which is more focused on sort of complex procedures that require additional training, and often it's centered around the pancreas and the bile duct. But nowadays, there's a lot of other procedures that fall into advanced endoscopy, like third space endoscopy, where we go between the layers of the wall of the gut to do certain procedures. Also, endoscopic suturing procedures, which can also apply to obesity-related treatments. So weight loss procedures where we actually can sew down the stomach and reduce the volume of the stomach. So there's a lot that we can do nowadays within endoscopy. And so that's really why I got into it.
That's really interesting. So for the suturing, do you have like 9 different cables that are going through this? Because it's a main tube, right? I know very little about this. So it's a main tube, and then in the tube, you kind of put through all your instruments and things like this, right?
Yeah, so the one sort of commercially available suturing device right now is an attachment onto the scope.
Got it.
And it's a certain kind of scope that has, or the one that we most often use, has 2 channels in it, which allow us to pass more instruments down. So yeah, there's multiple different kinds of scopes that we use, like ultrasound scopes and whatnot. So there's it's not just one specific scope that we use. There's a lot of different options.
I almost picture it like a video game. Like if you're really good at video games, you're gonna. I mean, of course, if you fail, it's not the character that dies, but the human. So it's probably bad. But it's like because you're looking at a screen, right? And you have a controller in a sense, and you're kind of maneuvering things inside the screen, right? Because I guess you can't look inside down the throat, right?
Yeah, absolutely. I think that's a really good comparison. And there are actually some studies that show that if you're good at video games, you tend to do better at procedures. More like, I think the studies are more in the surgical field, but it's similar. It's a lot of hand-eye coordination and depth perception. So you're absolutely right.
That's really good. And I'm guessing there was a little, like if you take a new fellow or a new resident on, there's got to be a learning curve, right? With learning the new controls and like even with the basic, if you're doing a basic colonoscopy or a basic just looking at an endoscopy to see if anything normal is or not normal is there, just the maneuvering of that thing is a whole new field,
definitely. Right? I think when I had the misconception or misperception that when that gastroenterology was just simply throwing a scope down a tube, but really it's much more nuanced, and there's a lot of body movement. Especially in advanced endoscopy, there's a lot of fine motor control, and then also I'm noticing that over the years I've learned that I'm moving my waist, I'm moving my elbow, I'm moving, my body in all sorts of different directions to maneuver the scope the way I want.
Are you putting the scope? We're going down a real rabbit hole here. But one GI, what's this colorectal surgeon? One colorectal surgeon I know has this like hook, and he puts the hook around his neck, and then so it's like the weight's on his neck, and then he has the control here, and do you put the tube in any weird, do you like wrap it around your waist? Is it on the floor? Is there any kind of weird positioning of the tube?
Depending on what kind of procedure it is, I do sort of offload the weight of the scope sometimes just by like resting it up against my body or putting it on the bed. But ergonomics is actually a really hot topic within GI as well, because over years, you can really develop shoulder problems and back issues, especially because in advanced endoscopy, we're often wearing lead aprons, which is an added weight as well. So these are really valid questions because it wears on us.
When did and if you don't know, this is completely fine. When did endoscopes first come into play? When did we first have a camera on the end of a tube that we were sticking into people?
Well, I would say it was probably the early to mid last century, but it originally was a rigid scope. So if you can imagine, it was a very different kind of procedure. And now they're flexible where we can actually, bend the tip and, and it's just a totally different experience for the patient as well. But there's been a lot of advancement, and, advanced endoscopy as a field really, I think over the past 2-3 decades came into its prime. Like before that, it really didn't exist, and it's because of all the new technology developments.
No, it seems really cool, and I can see how I'm interested in gastroenterology too. It's so early for me. I have to do the internal medicine first, and then I have to do, of course, gastroenterology if that's still. But the advanced endoscopy sounds super cool to me. Super cool. But let's back up to you. Enough about me. Let's go. Did you know in medical school you wanted to do gastroenterology or no?
Not at all.
Not at all.
I kept an open mind during med school. I thought thought I was going to do everything from neurology to orthopedic surgery to plastics. And I ultimately decided on internal medicine because I was actually not interested in GI at the time, but in pulmonary critical care. And once I started internal medicine residency, I explored interventional cardiology. And realized that wasn't for me either. And then that's when I decided halfway through residency that I was going to do gastroenterology.
Wow. So was it a moment in residency or was it a slow burn? Was there like a moment where you're like, wait a second, what's the guy doing in the room over there with the tube? I want to do that. That sounds cool. Or was it just like, I kind of like the digestive system, kind of like the idea around being in this profession, and I'll do it. And over time it happened. Was there any epiphany event or anything like that?
Yeah, there wasn't really an epiphany. I think it was kind of, in some ways, process of elimination, and in other ways, kind of just discovery. So going through med school, I think I always liked kind of the more procedural side of things, but I also really respected the internal medicine residents that I worked with. So that's what drove me into the residency program. And once I was there, I realized, I really do enjoy procedures a lot more. And, the pulmonary critical care part of it, I thought was really cool. I still think it's super cool. I really enjoy the critical care portion, but maybe not so much the pulmonary, the lung disease side of things. And then for cardiology, also think that what they do is just phenomenal and clearly very, critical. But I think it was very confined to one main organ system, whereas in GI, there's just a ton of variety. And, kind of the procedural aspect of things just spoke to me a little bit more. It was much more macro, I would say, rather than kind of like micro. And really, I noticed that all my friends were going into GI as well. And that's when I started thinking, okay, like what is it about this field that that was attracting everybody? Because I wanted to learn more. And once I did learn more, that's, I was hooked.
And what was learning more? Was it participating more procedures? Was it kind of talking to more GI doctors? Was it watching YouTube videos of endoscopies?
I wish I could say YouTube videos, but back then I feel like there wasn't as much on YouTube about this.
You don't live stream your endoscopies or anything like that?
Yeah, no, and back then I don't know if anyone was. But yeah, I think I definitely spoke to more GIs. And got involved in some research as well, and just read up a little bit more about kind of what was happening. Back in the kind of late 2000s, there was a movement called NOTES, which stands for like natural orifice kind of endoscopic approaches to surgery, and basically what that movement was about was trying to think about all the surgical procedures and see how they could make them more minimally invasive with endoscopy. And I think that seeing that kind of in the wake of that movement, I was able to appreciate kind of so much of what GI was doing and where it was going. And so that's really, what got me into it.
That's
more.
Interesting. And then in regards to the critical care aspect, there are certain times in the hospital, right, where you're the only guy that can kind of come in and save the day, right? I don't know. I'm thinking like variceal bleeds and things like this. Like if it's an esophageal variceal bleed, like you're the guy that's called, right?
Yeah, there are certain procedures, just like in any field, there are emergencies that we have to deal with. And in GI, like general GI, most commonly are bleeding events, like variceal bleeds, like you said, if someone's vomiting blood and we got to go down and figure out what's going on. Also, food impactions are another one, or, swallowed foreign objects, or like colonic obstructions. So in advanced endoscopy, though, the main thing that we deal with are either cholangitis, which is infection of the bile duct due to maybe a stone or something else, like causing the bile to not be able to flow out the way it should, or a perforation, like esophageal perforations, for instance, after some type of procedure. And interestingly, in the past, we traditionally think of perforations as something that surgeons have to handle, but there are times where we can actually deal with it ourselves with devices like endoscopic suturing devices and whatnot.
That's really cool. That's really cool. So before you got to advanced endoscopy, what was the fellowship like? What is the GI fellowship like? Are you doing rounds in the hospital a lot, like an internal medicine doctor? Are you in the rooms doing scopes the whole time? What does it look like?
Yeah, I would say that most fellowship programs are focused on inpatient GI, which is very different from outpatient GI because you are dealing with more urgent kind of conditions. But it also depends on what fellowship program you're in. Some are more clinical heavy and others are more research centered. And so I was at a more research research-heavy program, which meant that, my clinical work was very front-loaded. So my first year was very intense in the hospital, like all the time rounding, seeing patients, seeing consults. Some hospital or programs have consult services where you're there to kind of consult on top of a primary team. Others have their own primary teams and have to like not only manage the GI side of things, but also the medicine side of things. Yeah. So, it really depends on what your program is like and where you go. And that might be, a reason why you want to go to one program over another.
Yeah. Did you like your fellowship?
Yeah, I loved it.
Yeah.
Yeah. I think that, Brigham and Women's is a place that is more academic in the traditional sense of the word. But because of that reason, and it attracts faculty that are very innovative, kind of really pushing the envelope and at the cutting edge of the field.
And then you did like 2 fellowships, right?
Yeah.
But did you do, I remember we were talking earlier and you said you did a fellowship during the fellowship.
Yeah.
How does that work?
So because my program was more research oriented, it allowed for more time to do research or other things. And so it was almost an expectation to do something else. And because the leader, father of bariatric endoscopy, which is kind of endoscopic weight loss procedures, what is at Brigham and Women's Hospital, I, naturally was exposed to it, got interested in it. So I spent my 3rd year doing that second fellowship. So it was kind of built into my 3-year fellowship program. And then on top of that, I also got my master's in public health during fellowship as well. So unlike what a lot of people might assume, it wasn't during medical school, it was actually during fellowship.
Yeah. What was the most time-intensive part of your training? Was it residency? Was it fellowship? Was it the advanced endoscopy fellowship in that final year?
Ooh, that's a really good question. I think residency was probably the most time intensive. It also was the least flexible in the sense that, there are random days of the week where you're given off and you don't necessarily have weekends. And so it's just a little less kind of, it wasn't as kind of the normal schedule that you would expect. Advanced endoscopy was very time intensive as well, but it was a little more of a traditional kind of Monday to Friday schedule. So, it allowed for, you to be able to carry out a normal life more or less. But yeah, it was still very time intensive. Early mornings, late nights, kind of procedures all the way through. And, when you're in the hospital doing these procedures, you're constantly on. Yeah. And so it is, both physically and mentally taxing.
Wow. And can you tell me a little bit more about this obesity medicine? Is it, because I'm thinking of counseling patients, to eat less and exercise more, but is it more procedures? Is it a little bit of both? What is obesity medicine?
Yeah, so obesity medicine, even outside of gastroenterology, there are internal medicine doctors or other doctors who can have a focus in obesity medicine. And a lot of it is counseling, but also kind of an understanding of prevention and also treatment. So like medications and what other kind of treatments are available. And often that also means referring to a proceduralist who can do endoscopies or surgery as well. So I think it's understanding that there's a spectrum of treatments for obesity, and then from there, kind of following patients long term, because it's not just kind of a one-off treatment. It's really a chronic condition that requires a lot of partnership, I think, with the patient.
And you have this special combo for these obesity patients, right? Because you got the GI, you got the internal medicine, the advanced endoscopy. Are you doing, they don't do endoscopic, like Roux-en-Y's or anything like that. That's not a thing, right?
Well, no, not per se. Yeah. I mean, we have the ability nowadays to place stents to do kind of a bypass procedure, but not specifically for weight loss purposes.
Got it. Okay.
But there are, kind of what the surgeons do with a sleeve, which is the most common kind of weight loss surgery nowadays. We're able to create a sleeve as well without removing part of the stomach. We're just sewing the stomach down from the inside to make it more narrow. So it has the shape of a sleeve, but you're not removing part of the stomach the way the surgeons do.
Do you have to make sure there's no hole, so there's no that little pocket of stomach that you're cutting off, right? Yeah. I guess you have to make very sure that there's no little hole that the food's gonna leak in there and then get trapped. I'm just as random.
I mean, it's not. It's really not that bad. Like the way we place our sutures, it sort of minimizes that. But the weight loss outcomes are admittedly not as high as the surgical procedures, but
okay.
at the same time, there's also a little less risk associated.
That makes a lot of sense. And then you said the advanced endoscopy fellowship was the most time intensive. Other than the time, what was it like? Did you love it? Did you like it more than GI fellowship and more than internal medicine residency?
Yeah, I think the further along I went in my training, the more I enjoyed it because it's just more focused and like what I wanted to do, ultimately, and much more relevant too, because you were closer to kind of finishing training and knowing that, okay, this is what the next step as a full-time faculty member, as an attending would be like. So it was much more relevant.
Yeah, and then the mainstay of the training is, I think you mentioned this earlier, you're putting stents and things like this. Is there any other examples you can think of that mainly kind of, trying to think of the right way to say this, but clinical focused advanced endoscopists do?
Yeah, I think, it's also, cancer diagnosis, like biopsying tumors in the pancreas or other areas, and then treating complications of that too. So like you said, stents, but also, there are some modalities where we're able to go in and actually melt away the tumor using lasers, using other types of like photodynamic therapy.
Wow.
Also just removing stones, simple things like that, dragging out stones, crushing stones in the bile duct. And then what I mentioned earlier about third space endoscopy is an exciting field because when you're able to go between the layers of the wall of the gut, you can carve out tumors if necessary without, with preventing an open surgery or resection. You're able to spare patients a lot of potential risk with, people who've had to previously undergo a gastrectomy and have part of their stomach removed. Now you can carve out a tumor and leave the rest of the anatomy intact.
Yeah.
There's also conditions like achalasia, which is where the bottom of the esophagus doesn't relax and people have swallowing issues. And rather than having an open surgery for that, we're able to go in between the layers of the wall, cut the muscle, and relax it now. So it really spares patients a lot of.
That's really cool. Because historically, did they used to just dilate those things like by force from the inside, right?
Yeah, that's like first line. And there's, but then, over time, if that doesn't work, then we've got to, think about a way to actually cut the muscle.
How new is this third spacing procedures? Because it sounds really cool.
Just within the past, I'd say 5-10 years in the U.S.
Wow. And are there any other? Because you said, okay, you're gonna get some tumors, achalasia. Anything else you can think? It seems like.
Yeah. Well, other things.
Quizzing you here.
Yeah. I mean, like, there's other things. Well, not necessarily advanced endoscopy, but just general GI. How we treat bleeding, for instance. There's like so many different ways that we go about that. Mechanically, we can clip, we can burn, we can spray. There's like hemostatic powders now where you just spray things on, and then you're able to stop the bleeding that way. I mean, there's a lot of other types of cool procedures you can do.
That's so cool. So you do the fellowship. Now you're an attending. You're in a clinical attending. Not now, because we'll get into that later. But then you're a clinical attending. What's that like? What's it like to be an attending, finally?
Yeah, I think everyone's experience varies a little bit.
Yeah.
But, when you start out, it's a little rough because you're having to make the transition from a trainee into actually taking responsibility entirely for your patients and calling the shots and making those important decisions. And really, it's also kind of managing relationships with your patients, with your referring doctors, and just seeing how to grow your practice, how to develop your practice, but also it's lifelong learning, because these procedural techniques change, the science also evolves. You kind of have to keep up with it. So, what's being done now is different from 10 years ago, and 10 years from now, it's similarly also going to be different.
Going to be different, and then you're a leader as well, right? How is that? You have to lead medical students and fellows and nurses and PAs and all these technicians, and what is that like?
It's actually, I think, a good thing because when you have students, part of the reason why I like to remain in an academic center is when you're teaching fellows and residents, you kind of have to keep up. You have a responsibility to know what the latest and greatest is, and it keeps things fresh.
Yeah. What is the best part about being a clinical GI doctor?
I think it's probably, what comes with a procedural field, which is the gratification, the instant gratification with, having a procedure be done and knowing that the patient is better because of it. Sometimes when you're treating chronic conditions, like medically, you might not see very dramatic results right away. And so this gives you that instant satisfaction. And I think for GI specifically, because what you're treating is very macroscopic, it's very tangible. You're removing a stone, you're, stenting open a blockage. These are things that you can actually see are making a difference.
Yeah. And the counterpoint to that question, of course, is what is the worst thing about being a GI doctor, a clinical GI doctor?
Ooh, the worst thing I would say is probably just like not specific to GI, but just the dealing with the bureaucracy of our really complex health system. And I would say probably what a lot of doctors would say about documentation and dealing with insurance companies, like those things were, certainly not immune to in GI as well.
Yeah, I know that makes sense. And I'm going to just put this out there briefly. Because right now, what's the percentage of time that you're practicing as a clinician?
Yeah, so I am still 20% clinical.
20% clinical. Okay, we're going to get to that. I just want to do that as a little foreshadowing event because I keep on talking about in the past clinical stuff. When you were an 100% practicing clinician, what was your average schedule like? What would an average day look like?
Because I'm at an academic center, they also have time set aside for us to do kind of administrative and academic activities. So even though I was 100% full-time, there was usually a day that was more research, kind of academic, administrative day.
Got it.
There's one day that was devoted to seeing patients, new patients or follow-up patients in clinic. The third day would be, inpatient procedures where we would cover all the advanced procedures for hospitalized patients that day. And then the other 2 days were outpatient procedures. So we are very procedurally heavy compared to some other, medical fields. And so, if you think about it, only one clinic day and the rest being procedural essentially.
Wow. Do you see outpatient, like you don't see general GI issues in the outpatient? You would just see kind of advanced endoscopy follow-ups or preparations?
Right, yeah, for the most part,
okay.
yeah, exactly.
And then the academic day, is that teaching classes? Is that conducting research? Is that having meetings? What does that usually entail?
Yeah, because we're so subspecialized, really the main training that we do is on the job with our advanced endoscopy fellow. But we do have, requirements in teaching kind of the general GI fellows, lecturing every once in a while. I have a lecture a year for the medical students.
Got it,
and then, the rest of the time is, meetings and research type meetings and, actually doing the research. And so that's pretty much it.
Yeah. What do you think are the characteristics of someone that would excel as a gastroenterologist?
I think that having interest in digestive diseases, first of all. Oftentimes procedural interest as well. Like if you don't want to do procedures or you're not comfortable with that, then it's probably not for you. Although there are more medically geared subspecialties within gastroenterology because advanced endoscopy is not the only subspecialty. But I think that those are probably like the main things that you would want to consider just as like a screening test before getting into GI.
Can you tell us a little bit more about some of the other further subspecializations after gastroenterology?
Yeah, definitely. So aside from general GI, which is a little bit of everything, so it doesn't mean that it's completely separate from these other fields, but especially in academic centers or more kind of tertiary care centers, there are specific specialists who are focused on inflammatory bowel disease, GI motility, liver transplant, like taking care of patients before and after they get their transplant. Sometimes functional GI disorders, advanced endoscopy. I'm trying to think of what else. Medical pancreatology is another one. And some of these fields actually have dedicated fellowship programs and or like a whole fellowship kind of system. So like advanced endoscopy, there's an entire nationwide match. So it's kind of like a different match. Or another match on top of what I had to go through, between med school and residency and residency and fellowship.
Wow. That's really interesting. I think that's going to be really helpful to definitely people who are interested. It helps one of me. I'm going to take notes later when I watch back and edit this episode. Let's get on to the good stuff, because of course that's really interesting. But you have this really amazing and interesting background career. You're a social media superstar. You've done things at the White House. And now you're working as this chief of business for one of the biggest, is it the biggest medical device company in the world, right?
Yeah.
So let's start with that. What is this job? What is this Medscape thing?
Yeah, so, chief medical officer for Medtronic, the biggest device company in the world. I'm the chief medical officer for the GI business.
Yeah.
So, it's the CMO job differs for, different CMOs across the business, and probably differs, it also differs if you do a chief medical officer search on Google.
Yeah.
Often what you're going to get are chief medical officers of hospital systems, which is an entirely different job as well. So for me, for a medical device company, we're involved in the development and commercialization of medical devices. Like all the fancy tools that we use in advanced endoscopy, are made by medical device companies. And so, for me, I directly oversee certain functions within the business, such as medical education, where we actually educate the doctors on how to use these devices, clinical training for our sales team, because these are sales reps. They are there to support the doctors when they're getting to know how to use these procedures, and often have to in-service the staff at the hospital in how to support the doctors in using these devices, and also kind of physician relationships and society partnerships as well, because we partner with the societies often to support the programming and do things like that. And so that's really what I directly oversee. And then as an individual contributor, I'm also involved in a little bit of, clinical trial design, research and development, and also business development, which is like a particular interest of mine, because those are the conversations where we're talking to a bunch of different startups throughout the year and seeing if there's potential partnership opportunities or, potential acquisitions that we want to make if we're going to, buy the technology from an existing startup to include into our portfolio and actually kind of make it more widely available to everyone across the country.
That's interesting.
Or the world.
So business development is like so you're investing in companies, and this is really where you're deciding where the Medscape money, where the research Medscape money is going to go.
Medtronic.
Medscape. That's what I was researching the happiness and things scores. Yes. Where is Medscape going with their next device? No, Medtronic. It's a Sunday morning, people. Okay. So
I do know the Medscape guys too. But.
You do? You know the people that run Medscape?
Yeah, I do.
What are they? How did they do that?
I don't know.
Yeah.
I have no idea like what goes into that.
Yeah. Okay. I'm just interesting. That's so funny. Okay. Medtronic. So you're deciding where the Medtronic money goes. So you're saying, we love this scope. We're going to put all the money in the research into developing, commercializing, and kind of making this widely. Is this also doing like what is it, 510K? What is it called? Medical device approvals and things like that?
Yeah. So, 510K is one of the pathways to get a medical device approved. That's more kind of in the realm of regulatory.
I see.
But for let's say somebody has an idea or a prototype of a new device that they're making, and they need to, do all the testing, and then go through trials to potentially get approval by the FDA. Yes, there are considerations like making sure that they can get through the regulatory, agencies here, the FDA in particular. That does go into the decision making for business development agreements.
How do you get a job like this? How does someone, because you are attending for how many years now?
I'm very junior in my career compared to a lot of other chief medical officers, especially at publicly traded companies like Medtronic. So I am only 4 years out from training.
Wow.
And I didn't anticipate going into a role like this at this point in my career either. I was actually approached by my current boss, the Medtronic GI president, Gio DiNapoli, with this opportunity. And so when I was presented with this, I had to do a lot of soul searching to really figure out, okay, is this really a path I want to take? Because it's so different. Yeah. It hasn't really been done before within GI, because in a company of this scale, previously, there are other companies that have chief medical officers, but they're not GI doctors. And so, here I am walking into a GI business, as the first chief medical officer for the business. And so there are a lot of unknowns, but also it was exciting to kind of think about the prospect of it.
Can you take me a little bit more into your head? How do you go to start to decide? Because it's a big decision, right? Clinical medicine versus industry.
Yeah. Well, I think one key thing for me was I didn't want to give up clinical medicine.
Yeah.
I thought that the two should go hand in hand. So I wanted to continue my clinical practice to a certain extent. And so I said that in order for this to work, I need to be able to still practice. And so that's what made it a little bit more challenging, I think, than a traditional step away from clinical medicine. But yeah, I had to really think about, okay, what was it? Where were my priorities? Do I really enjoy kind of the academic trajectory? And what was it about this opportunity at Medtronic that I really enjoyed? And so ultimately it was because of, technology. That's really what got me into GI in the first place. And to have the opportunity to potentially play a role in technology development was very exciting for me. I think part of my goal with being on social media for the longest time was just reaching a wider audience. And but in that world of social media, I never really had a clear direction of where I would end up with that. And this was a very tangible way of saying, okay, here I am also having a population level impact with, introducing new technologies that could impact millions of people around the world potentially. So that was super exciting as well. And, just also the idea that this was like a global opportunity as well. Just, super exciting for many reasons that way.
That's super cool. Do you ever anticipate leaving fully clinical medicine? I know you said you think they go hand in hand.
Yeah.
But if you talk about business development, it's interesting. Business development it's not very much clinical involvement at all, right?
Yeah. I can't say never say never.
Yeah.
But I think for the time being in medical devices, I think that this is, it makes a lot of sense right now. Without having that clinical kind of exposure. Right now in the short term, since I'm still early in this role at Medtronic, it might not seem like it makes much of a difference, but fast forward 5 years, 10 years from now, when the technology or the techniques have evolved, there are other technologies out there, I would have no clear grasp as to what doctors are actually doing out there and how they're feeling about these technologies. And I think having my eyes and ears in the field is really helpful that way.
No, this makes definitely a lot of sense. And then what does your schedule look like right now? So let's say, is it like 1 week a month? Because you said 80-20%. Or is it 1 week every 5 weeks that is in the hospital and then 4 weeks working? What does it look like?
Yeah, on average, it's about a week a month, but it's not necessarily all consolidated into 1 week.
I see.
So sometimes it can be a little hectic, having to come back just for a day and then leaving again. God. But yeah, my weeks are pretty unpredictable. I am traveling a lot, less so now that it's like the winter time. But yeah, I was traveling pretty much almost on a weekly basis, going to different hospitals, having different conversations with various key opinion leaders around the country, going to courses and conferences. So it was exciting, and I think that it's been a great learning opportunity to get a sense of the entire landscape of GI and understand healthcare in general and how it operates outside of my own single institution.
Yeah. Are there any specific nuggets of things that you've learned in this past year, specifically in what you just mentioned, GI landscape?
Yeah, I think that it's just become much more apparent to me that consolidation of a lot of GI practices has accelerated a lot over the past couple of years, and we have these mega GI practices out there that span multiple states and are able to actually, help out with research and often have, way more physicians and patients than any single academic center out there.
Wow.
And so it's interesting to see, what they're able to do, and they can move, I think, with a little more agility than some universities too.
Yeah.
So we'll see kind of how the landscape continues to evolve. But I've also had a lot of lessons learned about, what it takes for doctors to adopt new technologies and exactly how innovative GI is versus maybe some other specialties.
Yeah.
I think we're less early adopters than we think we are.
Got it. So you bring some amazing new technology and you have evidence, you have these things to show them, and some doctors are like, nah, I want to keep writing my notes on paper, basically. Kind of thing.
That's a good analogy. I think by nature, I think a lot of doctors are risk averse and want to do things the way they've always done it. And so it does take a little bit of convincing to get them, on board and then past the learning curve of using a new technology. So, there's a lot that goes into it, even after a new product is introduced onto the market.
Wow. And that sounds like a lot of travel. Do you think you're busier now or when you were a clinician, were you busier? 100% clinician.
I think I'm busier now. I think my hours are probably longer now, juggling all these different roles. Because if you think about it, even though it's 20% academic and clinical, there's a lot of spillover with patient follow-up or doing research, because I'm still actively doing research and involved in societies, from that standpoint. And so the hours are longer, but I would say the intensity of it is maybe a little less in that I'm not, having to focus the way I do during a procedure where it's constant, laser focus for hours on end, which can be really mentally draining.
Yeah. What is an average week I was about to say Medscape again. What was an average week like at Medtronic? Are you flying on a Monday, coming home on a Thursday? Are you waking up to emails at 7 and meetings at 11? Or what is anything, an average day?
We try to keep it as, normal as possible to a regular kind of 8 to 5-ish type schedule. But I mean, there are definitely weeks where I'm in multiple cities. There was one week where I was in Salt Lake, then Baltimore, then Orlando, and then San Francisco all in the same week. That I won't forget that week.
Jeez.
And then there are other weeks where I am in the same place for the whole time, and their meetings, I think the fact that we're doing a lot of meetings via Zoom is probably different than how this role maybe looked a couple of years ago. So I only know how I do it nowadays. But yeah, it can be a lot of travel for that reason. But, we try not to do things after hours just to maintain a little bit of kind of work-life balance. But it's hard because we're across the country, across the world. There are different time zones involved. And we have to kind of take that into consideration.
And being in this leadership position, I mean, you kind of always have to have the phone on, right? If something goes crazy wrong, right?
But I've been used to that.
Yeah.
Maybe
True, I guess.
growing up in this generation and being on social media all the time, I am on my phone anyway.
Yeah.
So it doesn't bother me as much as I think maybe it would other people. And so, that part doesn't bother me too much. But I do carry 2 phones now, so that's the difference.
Wow, 2 phones. I guess hospital phone.
Yeah, and then the Medtronic phone. Because
which one's the personal phone?
The hospital one. Because that's the one where I, have Epic access and have patient information. So I wanted to keep that separate, from my Medtronic.
Did they give you an iPhone? What phone did they give you?
Yeah, I have an
14
iPhone.
or 13 did they give you?
No, so I
12?
personally have a
10?
12.
Okay, good.
Yeah, because I personally have a 13.
My voice is getting higher.
I personally have a 13, and then when I entered a year ago, they gave me a 12. So
okay, well we got to upgrade that soon. I think. What is this? I mean, you're heading all these, and they're giving you a 12. This is hopefully they'll hear this. We'll send this directly to the boss, and you'll immediately get a 14 max. Maybe
I'm happy with it right now. It does the job.
Don't say that. We'll get you an improved one. So it's a big decision, right? It's kind of. You've made the decision, I think, really, to go on a different path than maybe the average, because I'm in med school, right? I used to think, and which is one of the reasons I love talking to someone like you go to med school, you become a doctor, you go through residency, maybe a fellowship, and then you enter maybe academia or a clinical practice, and you're just a clinician for 30 years. Maybe you try to get a leadership, so you become a assistant professor. I don't know what the order, it's associate, assistant, I forget. And then full professor, and then maybe you become a chair or something like that. Was there any thought of these different paths and the decision to kind of go away from the completely academic medicine path to kind of the industry path?
Yeah, I don't know every single role in the hospital. I mean, I only really had visibility into, who was in my division. And so, ahead of me, there was the chief of endoscopy and then the chief of our division of GI. And then on top of that, there was a chair of medicine. And these are all kind of like the clinical leadership, right? Like there's also hospital administration, like the CEO of the hospital or like of the med school, like the deans of the med school and whatnot. And that I didn't explore quite as much. So the way I really thought about it for myself was like, okay, looking at kind of the most traditional pathway, within our division, like chief of endoscopy, chief of the division, did I really want to take on those roles one day? Is that really what I was working toward? And if I had to be honest with myself, I don't think that was something that I was interested in. And I was very, and there are plenty of people who aren't and can continue practicing in their roles like for their entire careers. But I wanted some sort of like career progression. And I think that as much as I appreciate the one-on-one patient interaction, I was always looking for a way to do something more on the population level.
Yeah. Is it very difficult to advance your career inside of academic medicine?
Yeah, I would say so. I think because it's I think mainly based on research productivity and publications. So, that is really dependent on how active you are on research, sometimes dependent on how able you are to get funding for your research, and what kind of research that you are involved with. So it varies a lot, even within GI, because some research is more kind of basic science based, and then there's others that are more like clinical research and just looking at patient outcomes based on the procedures that we're doing, which is more what advanced endoscopy is like. And so a lot of the innovation historically maybe was in academia for advanced endoscopy, where all these new devices were being developed. But I would say that there's plenty of innovation that's done outside of academia nowadays, when it comes to device development and whatnot, because it is so costly to do it. That it's kind of shifted in that direction.
It's a really interesting and important answer, because I spent a year at a VC fund, and it opened my mind completely, because I had no idea. These are the companies like the company you're at right now are responsible for deciding the way medicine goes forward in a way, right? Because they're funding these companies with these new ideas, and they're saying, listen, you're going to get the money to go forward, and we don't think this idea is going to have as much of an impact on patients, which is a really important sentence, right? You're deciding which devices, which drugs are going to have the most impacts on patients. And I always would think it's academic research and things like this, but no, there's money that needs to come into play to fund these things. These things are hugely expensive. Some drugs take $1 billion to create. Some drugs take, multiple billions of dollars. I mean, you look at these Alzheimer's drugs that went way down the drain, and with the genomics and things like that, it's just, it's crazy. So I think it's a really, really interesting point. And I think you're specifically cool to talk to about it, because you come from the top research institutions, right, in the world. You come from like Harvard, Columbia, these things. And it's very interesting to me, someone with your background who says, listen, this academic medicine, this academic research path, you've done a lot of thinking and you've decided, listen, I think the place where I'm going to have the most impact personally on patients is going this other path.
Yeah, I think everyone has a different journey. And, I'm definitely not saying that academic medicine, that the innovation that happens there is still very important to kind of drive our clinical, decision making. And, a lot of the innovation does start in academia, and then to scale it, I think sometimes, you have to bring in a bigger strategic partner. And I think that, academic institutions themselves are also, getting more and more involved in innovation themselves, and having venture funds of their own and fostering innovation. So I think that they recognize that and are also, shifting their way of operating.
Yeah, it's so cool. Let's talk about social media.
Okay.
How do you get to the White House? How do you talk? Do you talk to the president? Are you like sitting in that fancy Oval Office room saying, listen, the nuke code should be XYZ instead of a alphanumeric? We should just, what is that?
I did not get a chance to meet the president of the U.S., which would have been super cool.
Yeah.
Some of my colleagues actually did.
Really?
Yeah, but I was basically asked to be a part of this healthcare leaders in social media roundtable by a former White House fellow who was in the Office of Public Engagement. And, what they were realizing was a lot of the awesome new policies that were being rolled out, that wasn't getting messaged to the people who are actually potentially going to benefit from those policies. And being that a lot of people consume their information and healthcare information now on social media nowadays, or the internet in general, they felt, maybe a good way to go about this is having some of these health professionals who are active on social media help us with that messaging. So that's really how I got involved in that specific project. I mean, I ended up going to the White House a second time.
Twice
with
in the
my
White House.
Medtronic role, just to start conversations with the Cancer Moonshot team there. But that's a whole different story.
Yeah.
But yeah, the social media journey has been a decade-long thing for me.
How did it start, this whole social media thing?
Well,
Was it on Instagram, Twitter, Facebook?
It was Twitter. So
Twitter.
I mean, I've grown up in the social media era. So even before Facebook, there was MySpace and other things like that. And so Facebook came out my freshman year in college, and I loved it. I've always loved social media and loved how it was able to, bring us together. But then over time, I thought, okay, I'm spending so much time on social media. How do I make this more productive? And I also noticed when I was in training that there were patients coming into the hospital making decisions that were wrong because of things they were hearing, through TV, through the media, through social media. And at the time, I had spent a couple weeks at ABC News to learn how medical information got to the general public through the news and who was making those decisions, who was vetting the information. And in that process, they were using Twitter to host weekly Twitter chats about different health topics. So I was like, oh, wow, there are people showing up to this, and maybe I should start using Twitter for a more kind of productive purpose. And so I started live tweeting conferences that I was going to, tweeting about what I was learning in fellowship, and then ultimately started adopting other social media platforms, Instagram, then YouTube and TikTok and all these others, and kind of had to learn it all on my own, and learn a lot of lessons along the way about how to better message health information to the general public, and do it in a sometimes fun, less boring way.
Interesting.
Exactly, and that's really how it came about. So I think I would say the origin of all this was based on misinformation, and I think nowadays it's easy to assume that, oh yeah, misinformation on social media, like obviously there's a ton of it, like we should watch out for it. But a couple of years ago, that I don't think we had quite as much insight into all the misinformation out there, and certainly not as much into health misinformation. I think it took a whole pandemic for us to recognize that and acknowledge that, oh, social media can really have an impact on public health and public opinion of healthcare. And I think we're seeing a lot of, repercussions of the pandemic through, the effects of social media.
Yeah. And it's interesting because I think the same way, actually. I'm trying to think like when I was a kid, like 10 years ago or something like that. And seeing an MD, if I saw MD or doctor or anything on the TV, Dr. Phil or something else, I'd just assume they're right. Because they say MD, they say doctor, everything they say is right. But come to know now that maybe not necessarily, again, intentions are whatever, but maybe the information is correct or not correct. I'd never question it until thinking personally, I don't think I started to question things I saw on the internet, which is a crazy thing to say, until like maybe 5 or 6 years ago. I don't think I did. I think I just saw something, maybe because I wasn't as involved or personally involved, but I'd see, again, MD or doctor or even like PhD, and I'd be like, they're right. They must be right because they're MD, doctor, PhD.
And within our own field, when I was starting out, I had some of the faculty members who were, teaching me, thought that it was a total waste of time that I was spending on social media, and was very fortunate to encounter some other mentors who said, there might be something here. Maybe you should develop it, but turn it into something more academic, because that way it's more kind of legitimized and accepted. And so that's exactly what I did. I started doing research in social media, publishing on social media type projects, helping all of our professional societies within my field launch their social media presences. So it's been a long time coming, and I think a lot of people who see my social media presence kind of superficially don't see that there was a lot kind of behind the scenes happening.
I can only imagine the work that goes into it.
Right, and I mean, and you totally understand kind of like the actual content creation part of it, but then actually kind of legitimizing the space. When I started on Twitter, there were probably 5 gastroenterologists, and now there are hundreds, maybe thousands. And then ultimately, because of some of the misinformation issues that I mentioned, some of us came together on Instagram, outside of my specialty as well, and we started the Association for Healthcare Social Media, which was a nonprofit to help educate health professionals on how to use social media both effectively and responsibly, because we recognize that, there's a lot of ways that this could go wrong in terms of, health professionals on social media. There have been people who've been canceled because of things that they posted. And I think it's because, we're held to a different standard as health professionals, and we need to maintain our credibility. And when there's people out there doing things that are inappropriate or overstepping boundaries, then it really hurts all of us. And we need to maintain the trust in healthcare in order to have better health outcomes.
Yeah. No, it's such a good point. I'd be scared though. I would be so scared. And I get and I'm glad there's people like you doing this, because I would be so. For example, I'm doing a YouTube video around sleep and things like this, and I've been planning this for a while. And I'm just so scared. I'm saying, for example, I talk about the association between people who sleep poorly and like not living as long. And I'm like, can I actually say that? Is that something that's backed up by the evidence? I have to make sure I say association as opposed to cause, all these kind of little things. But you're doing this on a daily, or we're doing this on a daily basis almost. Like, how do you research all these things and like have ideas that you just write on a list somewhere and say, okay, I need to research this statement, this statement, this statement? Or is it from clinical experience? If you're making comments about gastroenterology, you just know from your decade of experience at this point that this is the correct thing and this is the wrong thing. How do you go about making medical statements on the internet?
I think that, a lot of it comes with clinical experience and just knowing that, okay, these are what the most recent guidelines state, so I don't necessarily have to look it up. But there are certainly things that I want to double check just to make sure that I'm not misquoting something for sure. And nowadays, I think that, I speak a little less about GI kind of education as much as I want to share kind of my experience in my new role, because I feel like this is what's really unique that I have to offer.
Definitely.
But absolutely, I think that it can be difficult at first, and a lot of mistakes I've made as well. You kind of learn along the way just from feedback that you get from people who, comment. I mean, that's part of the beauty of social media, is that you get real-time feedback.
Yeah. And starting this nonprofit, being the chair of social media for a hospital, an academic hospital, do you have any advice? I guess we'll start broadly to institutions who are starting their social media account. Say, the community college down the road wants to start their social media account. Anything, mistakes you've seen people make, or anything you said, okay, you should do this or don't do this?
I mean, I think like any business, I would say that you have to know who your audience is. And then on top of that, I would also just keep an open mind to begin with, because I understand from an institutional perspective, they have to weigh their risks as well. And when it comes to social media use, there's a lot that can go wrong, and the institution wants to protect themselves as well. So, I think that because we have, for a health institution, this is where we have a kind of obligation to educate our communities and be that provider of medical information and knowledge. I think it's just still important to not dismiss it entirely, because there are institutions out there that will say like, absolutely not, no social media presence. I think
even now, they'll say that.
Wow. And I think that we have to really, try to just be a little more open-minded and open the doors up. But I think the other kind of underlying thing that's been difficult for any institution is that, as an institution, I think you can't expect to have like a viral kind of to have viral content all the time and then expect people to just flock to your account. I think that especially post-pandemic, or not post-pandemic, but like now that we've been in the pandemic for a while, people are just, are at more of an arm's length with healthcare, and are, maybe a little tired of the subject as well. So it takes a little more convincing for people to get on. And also, even though we know that individuals tend to fare better on social media because they're, it's easier to relate to a person rather than an institution or an organization, it's hard to convince the health professionals in their institution to get on social media, because it's a time commitment. So I would encourage all institutions to kind of think of ways to incentivize social media use. And I know that there are some institutions out there that are looking more closely at it, whether it's, promotion opportunities, actually, kind of valuing what doctors are doing, spending time educating on social media, and not only just publishing research papers. So hopefully one day we'll see the needle move a little more in that direction.
Yeah. And if I'm an individual, say I'm a medical student, a resident, a fellow, an attending, who wants to get started posting medical things on social media, or maybe just posting in general on social media, do you have any advice to the individual?
Absolutely. I think that, definitely check with your institution first, because every institution has a different policy. And, often they can be good partners, because, when you talk to the communications team, they might be able to help you out in certain ways. I'd also say don't just jump into all of the platforms all at once. Try to go one by one, because you'll get more efficient at it over time, but then you also don't want to burn out. because it's easy to burn out on social media too. And then, just think about kind of put yourself in patients' shoes and make sure that, you're not saying things that are potentially offensive. And also, just I think that for me, the reason why I, went on certain platforms when I did was also because I had to wait until I became more of an authority in my field to start talking about certain things, and to really speak within my lane. Like, I think that when I start talking about things outside of gastroenterology, sometimes it can be a little dicey. And there are, take the, COVID, for instance, there were moments where
Which is a very dangerous topic to post about on the internet.
I mean, at the beginning, I think that I had a public health obligation to raise awareness about it and say, to really encourage people to do certain things. But over time, when the questions became much more granular and more appropriate probably for a virologist or immunologist, I would refer people to those experts. So, and that's what I tend to do, when it's kind of outside of my own kind of area of expertise.
Yeah, you're allowed to say, I don't know, even as an attending doctor, right? I think it's an important statement because a lot of times, especially some of these, the doctors I most respect in the hospital, especially in the clinical setting, is when they not only tell their students and their trainees, I don't know, they also tell their patients. I don't know. I think it's one of the best. I think it's one of the most valuable and cool things I see.
Yeah, I mean, I think transparency is like the way to go these days. Like everyone is expecting more transparency and would prefer transparency, even if it's not in their favor, to just have full disclosure on those types of things. And I think, especially for students and trainees, I feel like I see it a little less often nowadays than it used to. Like, people would call themselves doctors before graduating from med school, or, there's also other, non-physician health professionals who would call themselves doctors as well. And it was just, confusing for patients. And I think that's where it goes back to putting yourself in patients' shoes and saying, asking yourself, okay, am I being misleading here? How will patients perceive this?
Yeah, no, it's an important statement because does it all come back to, right? It all comes back to the patients. And instead of because I get it in but I don't think I ever would say, sometimes they introduce me as student doctor. I'd be like, whoa. But it's,
I think that's okay.
You think that's okay? But I was like, whoa. But I usually just say medical. I think that's the best thing most people say. But for a lot of patients, I didn't even know there were fellows or residents.
Right.
I thought everyone in the hospital was a doctor.
Yeah, when I was, before I entered the medical field, before I went to med school, I had no concept of what all these different terms are and like how hospitals work. Right, exactly. And what the distinction was and what level of expertise really there was.
Yeah.
So I totally agree.
And a lot of these patients coming in the hospital, they're not like the chronic people that are there for it. It's like their first time ever. Maybe they're really sick in a really scary situation. So not only are they in a new place, but also their brain is probably not in the place that it normally is because maybe their inside's wrong, but also their outside's completely different too.
Yeah, it's like a totally foreign environment.
Yeah, it's crazy. It's crazy. Okay, side point done. Where do you see the future of your social media presence going?
I think as I alluded to earlier, I think it's probably more about sharing my unique experience, being in this interesting hybrid career role, because I do see more and more people in the future potentially taking on these types of hybrid careers, because I think that there's more to being a doctor than, just clinical medicine. And I think it's valuable for people with clinical experience to have a say and have a seat at the table when it comes to whether it's device development or pharmaceuticals or other technologies, because healthcare is an ecosystem. And as much as we are often the people who are, on the front lines in the field with patients, I think that perspective is really valuable to other aspects of healthcare too.
Yeah.
I think that, sharing that experience on social media is really great. And also just, I'll continue to talk about disease states because I think that that's just going to be an ongoing, directive to try to educate patients and everyone else about their gut health and about, their GI care. But those are kind of the areas that I'll probably be focusing more on. And, I'm still going to, from time to time, I think, talk about, the training process and kind of how I got to where I am and and all the trials and tribulations. Although there are times where I already feel like it's a little less relatable. I get questions about like, okay, how do I approach the MCAT? And it's like, well, that was a long, long time ago. And the MCAT, I think, is entirely different now. So I can't speak to it as well. But, I'll try my best to, share my experience because I think that that's something that I probably didn't value as much as I should have in the past. Like just speaking to people with far more experience than me and understanding, okay, what is it? Like, how did they come to, where they are and what influenced their decisions?
Yeah, and it's a really valuable point too, because I think it's really interesting to talk to you who's just done this change as opposed to someone who's been there for 20, 30 years. Because, right, for example, if I'm learning how to code, I've never coded in my entire life. I think I'm going to be better suited learning from someone who's been coding for 1 or 2 years as opposed to someone who's been coding for 20 or 30 years. The 20 or 30 year guy isn't even going to know anything about these little things. He just types these things they're just so deep in his brain at this point, he doesn't think about them. I really want to learn at the 1, 2 year guy who knows, okay, I was just in your shoes. I know exactly the questions you have, the difficulties you're going through. I want to talk to you. So especially someone like you who, just made this change. You've been there for a year now at this point. I want to learn from you. How do I make this change? How do I talk to my hospital about making these changes? Was it a good decision, do I think? Was it a bad decision, do I think? Were there things I would do differently? I think these are all really, so it's a great point in your social media time to talk about this.
Yeah, I think having an understanding of, the industry and the greater ecosystem as a whole is something that we're not taught in med school or residency even. And then, I just feel like there's so much that we could be learning, that we should be learning, I should say, in med school that we're not taught. And so, hopefully I can do my little part in educating on that.
Maybe you should start like a 4th year medical school course, elective, the business of medicine or something like that. I think that'd be awesome.
I've thought about that. And I know that there are actually programs out there, like Mass General has an academia industry type of year-long curriculum where I think they have like a lecture series. So I think that that's something that would be really helpful in the
but it
future.
shouldn't be a lecture series you know what I mean? I feel like it should almost be, I'm talking about elective right now. I think it should be earlier. I think you should learn this in like the 1st or 2nd year, maybe even right at the beginning when, you're not getting deluged with all these nitty-gritty medical information. You're just like learning, because I remember some of the first things we learn is like, ethics, like autonomy, beneficence, non-malfeasance, and justice. And maybe we're also learning, respect patients and all this thing. And then maybe we should also learn like, okay, this is where your career might go. This is different options in your career. This is how industry has an impact on what you're going to be doing for the rest of your life.
Yeah, or even just health systems in general. Because like what the patient's going through isn't just their disease. It's also, everything from the moment that they park at the hospital and they like, how do they navigate through the hospital to get to see the doctor? And then after that, like dealing with insurance and all this stuff. I think that that whole process, I don't think we are taught enough about.
No way. Yeah. And the reason I think it's important that we bring it up, because the ratio of like the way it's actually involved as a practicing attending or even as a patient to what we're taught in medical school is way, way off. Because we're like 0% in medical school, and maybe, I don't know, I'm not going to apply a percentage to real life, but there's definitely a decent percentage that's like, how are we going to get this paid for? How do we talk to the insurance company? What is the insurance company thinking about? Why are they making these decisions? Why is there such a confrontational thing? Why is the hospital pricing this at 10 times the actual cost it does? Mm-hmm. Well, maybe they do that because they have to, negotiate with the insurance company to get money so they can actually make a little bit of money so that they can pay for these devices and these drugs going future so patients can get these devices.
Yeah, if we had more awareness in general about what each other were doing and why we decided to do things the way we have, I think there'd be a lot more empathy.
Yeah.
And, I think there's just taking medical devices, for instance. I, know that before getting into this role, I'd be like, well, why is this device on back order? Why can't I actually get it? And what's taking so long? And now I have a greater appreciation for, why that is. And, if I share it with my colleagues, maybe they'll also, understand a little bit more about like, okay, this is the reason why. It's not because people are out there to like, spite us.
Yeah, no, exactly. There's very little of the time, that's definitely not proper English, but not often of the time there's actual malevolence. There's usually not evil intentions. And I think that's an important thing to think about. Usually, and I say 99.9% of the time, people aren't trying to be evil to hurt you just to hurt you. It's just kind of the way maybe uppers are telling them what to do, or again, very broadly here. But I don't think people are evil innately.
Yeah, I don't think so either. And I think that everyone's, just trying to make it work and trying to do the best they can,
Yeah. So if I'm interested, say I'm in medical school, say I'm applying to med school, if I'm trying to learn more about these industry things, because I maybe won't learn it in medical school, where can I go? Should I follow you and watch your videos, which I think they definitely should? But are there other places people can look to learn more about kind of these other opportunities?
I think it just depends on what aspect of, outside of clinical medicine you're exploring and just talking to people. I mean, I wish there was, I know that there are some kind of groups out there and informal groups, depending on what you're interested in, that you can join. And, I myself am also just getting involved in some of those groups like for the first time. But I'm realizing that it's just, pick up the phone or reach out to somebody. Like it doesn't hurt.
Yeah, have conversations.
Yeah.
I think is huge. It's huge. So as we get close to the end here, are there any mistakes you made throughout your career of medicine or your life in general that you think would be helpful to people to know? Like, is there any advice you would give your 18-year-old self or maybe yourself before you went into med school? Anything at all?
I mean, since we're on the subject of kind of things that we didn't learn in med school, I would definitely want to, have learned more about that on my own and spent more time on that. It was a different world. Maybe back when I was then, maybe like things weren't as accessible on the internet or YouTube at the time. There was just less content available.
Yeah.
But I think that it's hard for me to say that I, made any mistakes or regret anything because as the cliche goes, like without having experienced that, I wouldn't be where I am today. But I do think that, knowing what I know today, it would have been nice to just explore more of that. And, and I think it might help me navigate healthcare a little bit better today.
Yeah. No, that's really helpful. And I think this podcast has been amazingly helpful to people out there. As we come to the end, any closing words in general? This could be why you should do GI, how to become a better GI, how to get into a GI fellowship. Or this could be, this is what you should do for your lifestyle changes. It could be finance advice. It could be anything whatsoever, just closing words in general. Social media advice, anything.
Well, I would say kind of like what I said about my social media presence. When you look at it like a snapshot of everything right now, it looks like it was built overnight, that everything that I've done, like it seems like it was all done overnight. And it's like, oh my gosh, how do I do all of that? And I think it's because, I've done all this over such a long period of time. I don't want people to feel like it's intimidating or something that you can't do as well, because you can do it too. It just takes time to build things up and be committed to something.
Yeah.
But at the same time, I think the reason why I was able to kind of have some of these unique experiences was because I kept an open mind too. I think that there are some people who are just very pigeonholed in what they, in their way of thinking and what they want to do. And maybe that's, exactly how they want their journey to play out. But for me, I always wanted to like be open to other possibilities, and without that kind of open mind and, willingness to take a chance, I wouldn't be, I wouldn't have this hybrid career today. Mm-hmm. And I know a lot of people who would turn down the opportunity that I had, probably because, they thought maybe it would be too risky, or it might be, it was just too foreign for them. And for me, I was like, you know what? This is like a point in my career, weighing the pros and cons, that I think it was appropriate for me to take a risk, take it as a learning opportunity, and go from there, and so I can only imagine where I'm going to be in 5-10 years, because I'm, carrying that mindset forward. Yeah. So, who knows?
Well, that'll be great. We'll have to have you back then in those 5-10 years. But thank you so much, Dr. Chiang. You can find Dr. Chiang at Austin Chiang, MD on Twitter. So let's spell it out for the people. AustinChiang, MD. And that's on Twitter, TikTok, YouTube. You have a website.
Instagram,
LinkedIn, everything. The Be Real. We talked about this. You have a Be Real? No, you don't have a Be Real?
I have a Be Real, but
You're not sharing this at this point?
Well, I'm just not using it very much. There's just too much other
Snapchat.
things.
You have a Snapchat as well? You have a Snapchat? I stopped it. Maybe I should get back on the Snapchat. But this has been great. Thank you so much, Dr.
Yeah,
Chiang.
thanks for having me again.
Perfect.